Hey everybody, welcome to another PermanenteDocs Chat. I'm Dr. McDonald. Thanks so much for joining us. So today is, February is Heart Month, and talking about all things cardiovascular disease. And we have with us one of our amazing cardiologists, Dr. Kulkarni from Mid-Atlantic Permanente Medical Group. So Dr. Kulkarni has been on the previous versions of the chat before. So welcome back. Thanks for joining us. I think you're one of a couple of repeat customers here. So I guess we have scared your way. So thanks for joining.
Thanks for having me. Yeah.
Real quick, so just remind us, tell us who you are and what you do real quick.
Sure. So my name is Ameya Kulkarni. I'm an interventional cardiologist in Northern Virginia with the Mid-Atlantic Permanente Medical Group. And I wear a bunch of different hats. One of them is the chair of the Cardiovascular Institute at Mid-Atlantic Permanente.
Awesome. Wonderful. So as I mentioned, so February is cardiovascular month, and about 25% of all deaths can be attributed to cardiovascular disease, and the number one cause of death in the US. How do we reverse this trend? It's obviously not a simple solution, but I'd love to hear some of your thoughts.
Yeah, I think that there are a couple of mantras we can follow to try to reverse the trend. I think that the step one, which is the most important, is start as early as possible. One of the things I say is that if you have young kids at home, that's the perfect time to start a conversation about diet and exercise, because those are the habits that are built nice and early that will sustain our children throughout their lives. And then in adulthood, sort of the classic, the American Heart Association always says, know your numbers. And I think that's a really great way of just saying, well, what's the barometer of where your heart health is? And the numbers are really simple, right? Knowing your cholesterol, your blood pressure, and your weight. And if you know those three things, then you're 90% of the way there in terms of understanding your risk. And if you know your risk, you can figure out ways to mitigate that risk. And then the third thing is don't ignore symptoms. One of the things that happens as we get older is we have these symptoms, we're not sure what they are, and we want to say that they are that we tried to minimize them. And so if you have a symptom that's worrisome, have a conversation with your doctor, because I feel like what I always tell my patients is that you never worry alone. If you're worried about something, we can talk about it together and reassure you. So those are sort of the three phases of life and the three things we can do. And I think that if we just did those things, we started habits early, if we knew our numbers in adulthood and we didn't ignore our symptoms, that would go a long way towards reducing that trend.
I can't tell you, as a sports medicine physician and a primary care family physician, that that prevention is music to my ears, and that makes me so happy to hear. Especially with kids too. I'm a big believer in getting kids active and moving. So you talked about your numbers, so cholesterol, blood pressure, and weight. How does blood sugar play into that one? Because I know a lot of folks who have elevated blood sugar can also increase their risk of endothelial damage and increase cardiovascular risk as well. How does that sort of play into the equation?
Yeah, that's a great point. So blood sugar is sort of the fourth know your number, and so or hemoglobin A1C, depending on how your physician wants to measure. And that's really just, again, that's the barometer of your diabetes health. We know diabetes is one of the most prevalent chronic conditions in the world, and it is a risk factor for heart attack, stroke, kidney disease, all of the above. And so the more we can do to identify that early and treat it either with preventative measures or with medications in some cases, I think the more we're doing to protect ourselves from the consequences. So yeah, that's a great point.
Yeah, absolutely wonderful. Well, tell us a little bit more about the Mid-Atlantic, the Cardiovascular Institute that you have there at KP Mid-Atlantic, and what it does and what the goals are.
Sure. So, Kaiser Permanente in the Mid-Atlantic we cover a big geographic area. So we cover from north of Baltimore and Maryland, right at the southern tip of Pennsylvania, all the way to almost Virginia Beach, and then as far west as Frederick, Maryland. And so if you don't know your Mid-Atlantic geography, that's an enormous geography to cover. And what we wanted to create was a program that allowed patients to get the care they need where they are as much as possible, because we have this beautiful telemedicine-based virtual system where we can leverage expertise from really anywhere in that encatchment. So we wanted to create a system that allowed us to leverage expertise from all over, allow patients to get cared for by the doctor they trusted the most, their primary care doctor, as much as possible, and then also provide the highest quality care that we could in the fastest way possible. And so it's a small ask. So that's where our mission started out. And what that looks like is there's a few places where we really sort of honed our craft. So one is in speedy care. I like to talk about our structural heart disease program, a patient who needs their aortic valve replaced. So we have this technology where you can replace somebody's aortic valve using a catheter from the groin. So instead of having a 5-day hospital stay, they spend a couple of days in the hospital. You don't crack open their chest. You do it through a catheter in the groin. They're awake for the procedure instead of a general anesthesia. So overall, a better procedure, especially because these are often for patients who have who are older or have other comorbidities. And so that was an important technology that we wanted to offer to everybody. So we created a regional program that offers the technology to all our patients. We centralized it so that a few operators would do a lot of it, because you want your TAVR operator to be doing a lot of these. And then at the beginning, there were about 12 tests that you needed to do to figure out whether this procedure would work for you. And in most of the world, those 12 tests would happen as most testing in medicine happens, right? You get your one test here, your second test here, and it takes 6 to 12 weeks to get everything done. So we had this ambitious goal to get it done in one day. And so that's what we did. So we started what's called the one-day TAVR evaluation. And what that meant was that the patient starts their day at one of our medical centers, ends the day at a hospital because one of the procedures needs to be done in the hospital. And by the end of the day, we have all the information we need to make a decision about how to take care of the patient. They've met everybody they need to meet in terms of clinicians. We have all the information we need. And that allows us to not only take care of the patients faster, so from the time we've identified this problem until the time your problem is solved can be less than a week. But we also have reduced the inconvenience for patients. So now a caregiver is only taking one day off of work instead of taking several days. The care is all coordinated, so patients and their families are not having to take a CD from one office and send it to the other, and all that stuff that makes healthcare so hard. We wanted to just eliminate. So that's like the crowning example of what we hope to do. Now, we didn't stop there. So we took this paradigm and just in July of last year, we started applying the same paradigm to our patients undergoing a heart transplant evaluation, which is an enormously larger task, but much more important that the patient, because these patients are much sicker. And so we want to make sure that they don't have to move around that much to get the care they need. And so we've successfully actually done it since July. We have a one-day cardiac transplant evaluation, which I think at this point, we are the only system in the country that I know of that does that as a matter of regular course. And so, yeah.
That is absolutely incredible. And kudos to you and your team for having the vision to do that and actually create it. I mean, so many of the again, as a primary care doctor, I get all these messages from patients being like, hey, I have to get this test done and this test done and that person, and I'm waiting to hear back from this. And just to minimize all that administrative time and just to really care for the patient at the right time at the right place is just amazing. So kudos to you and your team. I think we have a lot to learn from you guys. That's amazing. Are there any other projects? Obviously, speed of diagnosis is really important. Is there any other projects you guys are working on? Is there something specific, you personally or your team is really thinking of, okay, what's the next step, or how do we even improve even further upon this model?
Yeah, so one of the things that has always been really important to me, and as a primary care doctor, you'll appreciate this, is that we want to really make primary care doctors the center of the patient's universe. I think that's such a thing that is easy to say and hard to do, especially in modern medicine, right? So my father-in-law is a family practice doc, and he's like the oldest of the oldest school, because he spent some time doing family medicine in East Africa and in Pakistan, and his model is that he is the patient's doctor and everything has to go through him. And, that's actually the right way to do medicine, right? That's actually the right way to do medicine, because you have this deep relationship with this person you grow up with, who then can sort of help be your advocate in this really challenging medicine world. And so a lot of the stuff we're doing sort of uses that as the core philosophy. One example is, atrial fibrillation is a common problem that patients have. I would say 50% of patients over the age of 80 will get some version of atrial fibrillation. So it's an enormously common problem. And historically, what happens when a patient gets atrial fibrillation is they get referred to the cardiologist immediately. And what we have done is we've actually spent a lot of time working with our primary care doctors so that the primary care doctor now is the center of the atrial fibrillation conversation. And we are offering sort of guided expertise in the parts that we know the best. But the person who is making the sort of thoughtful decisions with the patient about things like anticoagulation and about slowing down their heart rate, that's all going to the primary care doctor. And I actually think that we're making better decisions. We're doing a better job of hearing the patient before making the sort of decisions for the patient. It's creating this really interesting, it's almost like the village, I call it the village doctor model, where in the old village doctor model, your doctor lived in your village and would go from house to house and would see you at the grocery store and know what you're eating. And that was really good because they had all this collateral information, and we're sort of trying to recreate that in our model. So that's a personal that's of personal importance to me in how we structure our operations. Everything with the patient at the center, but sort of rethinking how a lot of American medicine has been to really be centered on that relationship between the doctor you trust the most and the patient. And if you start there and go from there, everything is better. I really think all the care is better. You're making better decisions. Patients getting what they need much faster. That's the hill I'm going to die on.
Hey, I'm going to die on that hill with you 100% because like I said, as a family doctor, I agree 100%. I have a lot of patients who end up getting sick or going to the hospital, and they come back to me afterwards and they have all these different medications, and some of them for anticoagulation, for atrial fibrillation. And we sort of talk about, well, you're 85 and you had this GI bleed last year. Like, do we really want to be on this anticoagulation? Yeah. And again, knowing him and knowing the patient and having that relationship is just so important. So I'm glad this is being recorded because I can share it to every single family doctor in the nation who I know. So yeah. I think that piece of one of the reasons I'm most proud to be a Permanente doctor is because it's really truly patient centered. It's not centered around the hospital. It's not centered around the doctor. We really can kind of collaborate care in a coordinated way around the patient, and that's really what makes me so proud. And it sounds like you guys have upped the ante out there at the Mid-Atlantic Permanente Medical Group, and we need to step up our game here in Southern California. But we'll make it happen. Don't worry.
I believe you.
Awesome. What are some kind of ongoing challenges that cardiologists continue to face right now, especially in the middle of this COVID pandemic? I know there's been a lot of deferred care, and I've heard stories of patients having chest pain and just staying home because they're afraid to go to the hospital in the ER because of COVID. Are you still seeing that? What are the biggest challenges facing cardiologists right now?
Yeah, so I'll tell you that for cardiologists in particular, and it's true for some other subspecialists as well. COVID itself has been a challenge because the disease creates some cardiovascular manifestations that we have to manage, and then you have patients who are sort of not seeking care when COVID surges, and so then we get these delayed care. So you get these COVID surges and these delayed care surges, and so for us, there's no valleys, And I think that's actually probably the hardest thing to manage, because now we're sort of completing the second year of the pandemic, of this constant flow of managing the surges of COVID and whatever comes with that, whether that's taking care of very sick patients or sort of managing our own anxieties and our own staffing issues. We've all, especially with Omicron, we were all struck with how many of our physicians and staff had to be sort of on isolation for a period of time. So I think that is one chunk. And then in between, we're squeezing, a ton of delayed care in. And you have probably heard this as well. The pandemic itself has taken a toll on our patients. Stress levels are higher than they've ever been. People are eating differently and maybe not as well. And their activity levels, the sort of what I call the sort of found exercise, the exercise of walking from your parking lot to the office or, going to lunch. When you're working from home, people are not getting that. And so their activity levels have changed significantly. They're not going to gyms as much. And so we're seeing this sort of all the advances that patients had made in sort of activity and diet and all that have sort of have taken a step back, and so now we're having to work with sort of having people reclaim their rhythm, that sort of figuring out what they used to do to stay healthy and bringing them back to that. So it's a lot together. With that said, and I have to say this because I think that there is also a lot of burnout among our physicians and staff. There's never been a harder or a better time to be a doctor, because the meaning of what we do is so clear. We're blessed in a way that we get to see the real meaning of what we do. We're actually changing patients' lives on a daily basis, and we're feeling their gratitude. And I think that's special. This is why when we were 8 years old and wanting to be a doctor, this is what we wanted to do. We wanted to take care of patients at their most vulnerable. And so I'm grateful for that.
That's amazing. There's never been a harder or a better time to be a doctor. I have to write that down. Because it's so true. It's so true. And I think no matter what specialty you're in, we definitely feel it. So awesome. Okay, we have a question here in the chat. Let me see. Everyone seems to be talking about virtual care, especially during the pandemic. How does virtual care come into play with cardiology?
Yeah, it's a great question. So I will say that this is an evolving topic. And so, pre-pandemic, in our system, about 50% of our visits, 50% of our interactions with patients were virtual already. So we were half and half virtual already, and using very creative tools. Like we had a remote data monitoring program for heart failure, which means, when patients with heart failure, they get a scale and a activity monitor that was connected to a system we could follow. And so we had a way of following them sort of without them having to change what they do or having to communicate actively. I think that one of the things that we are all learning during the pandemic is how much we can do virtually and what we can't do virtually. And I think that second part we're not talking about enough yet, but we will, because there are some overt things that are better in person. The physical exam, for example, on somebody with heart failure, the gestalt of how somebody looks. I think that that's harder to capture on video than in person. But I think the other part is, in medicine and in cardiology in particular, we have a lot of very serious conversations with patients, and some of those conversations you need to hold somebody's hand. You need to know you need to understand their vulnerabilities, and that's sometimes hard to capture on video. And so what I predict for the future is that you're going to see a rebalancing. A lot of the sort of care that was routine in the outside world, you're going to start to see that shift to virtual in one way or another. And then you're going to see sort of emphasis placed on important conversations to be done face to face. And I would say about the last year, we've seen that rebalancing happen. And I think that we'll continue to see that. I do think one thing that we're going to see a rebalancing of as well is all of the commercially available heart technology. So like I wear an Apple Watch, right? And it's great for it's great for activity monitoring. It's great for you to sort of understand, to make sure that you're doing what you're supposed to be doing. It also has a bunch of other features like the ability to detect arrhythmias and things like that, which we don't know what to do with that. And so I think you were still learning, whether that information has validity for the patient and clinical relevance for us. And so I think that reckoning and how to use commercially available data and turn it into information is going to be our next frontier.
Yeah, and we have so much data too. How do we then make it usable also, right?
Yeah.
Like you just information overload, especially at point of care. So how to synthesize that data into a useful way also, I think is even the next order of magnitude beyond that. So
exactly.
Awesome.
Right.
Well, we're almost out of time here. We have so many, you can go on forever and ever. So two more questions real quickly.
Yeah.
What are your own personal habits to maintain your cardiovascular health?
Yeah. So I do something called insanity. So my healthcare journey was that when I was in training, like all of us in training, you barely have any time to do anything. You're sort of working. If you can see your family, that's great, and if you can't, then that they sort of take that sacrifice too. And so when I started working at Mid-Atlantic Permanente, I wanted to make a conscious decision to find time for activity every day, but I needed to do it in my house. And so Insanity, which is the sort of, the high intensity interval training workout, seemed to be the best thing for me. And so I do that. I still do that probably 4 to 5 times a week. That's my main way of exercising. But I love running and I love biking, and so I do a lot of that as well. The thing that in terms of food habits, the reason why my food habits are so good today is because my wife is very particular about what we eat and how we eat, and in particular, she's really good about finding ways to make substitutions that don't make you forget that food is supposed to be fun and delicious, but also, remind us of nutrition. And so there's like simple things like, we drink sparkling water instead of soda. That's like a very simple sort of shift that it still gives you some of the, the mouthfeel and the fizziness, but doesn't give you any of the sweetness. My older daughter's favorite food is kale chips. It's a sort of roasted kale with salt, pepper, and olive oil, which has the same crunch and oily texture and salt, but doesn't have the fat content and has a bunch of nutrients. And so little things like that. But so that's sort of the way that we approach health. We are really pragmatic about our health, and so that's how we approach it.
Awesome. Yeah, no, I think you and I are very kindred spirits. I think when we get together, we'll have to go for a bike ride or a run.
Love it. I love it. Southern California has better bike trails than Mid-Atlantic, though.
I grew up in Vermont, so I grew up in the middle of the winter,
Sure.
So 9 months of winter. So it is a nice shift. But anyway, we do have another question here. This is actually a really good one. I want to ask you here. Do you have any thoughts or kind of, is there much evidence on the idea of intermittent fasting, where you fast for 12 to 16 hours a day, and what your thoughts are and recommendations are for your patients?
Yeah, so there actually is a randomized clinical trial on intermittent fasting. It was done in British Columbia. I want to say it was done 2 years ago now. It's actually it's a brilliant trial. It's the way that trials should be for nutritional studies. And I think they did a 16-hour fast. I want to say I have to go back and look at it.
Yeah,
so isocaloric, which means the same amount of calories in the group that was fasting and not fasting. One group was just told you have to fast in these hours. And they showed no difference in weight loss, no difference in the parameters of heart health, so cholesterol levels at 6 months, and I think they did it at 12 months. And so in a randomized fashion, that suggests that if your calories are the same and you only shrink when you eat, that intermittent fasting by itself is not a strategy that will help improve heart health or weight loss. Now, I'm going to put a big caveat here, because the two things that I will say is that the diet that works is the one that works for you. And so if intermittent fasting is a way that you can help understand what you're eating and control it better, then by all means try it, if it works for you. And then the second caveat is any diet that helps you identify what you're eating and reduce the total amount you eat is a good diet in my mind. Whatever the diet you choose, it's about making better choices. So mostly fruits and vegetables, lean proteins like fish when you're going to eat proteins, and then avoiding complex carbohydrates and sugars. Like if you just use those principles, whatever other sort of mechanisms you have are great. So yeah.
Yeah, I think that's great advice. I always tell patients you have to figure out what works for you and your body's metabolism, but then also what works for your lifestyle as well. I have a lot of patients who are long distance truck drivers, and they're literally on the road for 8, 9, 12 hours a day. And they're not going to be able to eat the same way that somebody who would, who has available access to a refrigeration, for example, too. So I completely agree with your comments and your thoughts there as well, too. All right, last question, although it pains me to end our discussion, but last question. What are you most proud of to be a Permanente physician?
I think the thing that makes me most proud of being a Permanente physician is that we get to practice medicine the right way. I feel like, and I know you're on Twitter as well, and I feel like there is a about every few months or so, there is some complaint from a physician about the way they're practicing medicine and how it deviates from what their ideal way was. And that doesn't happen to me. I don't, there's never a time when I am making decisions or doing things for a patient that is contrary to my ethos. And that feels really good. And it's sad that it's rare and challenging to find that in 2022 in American medicine, but that's the truth. And, I feel like I feel lucky to do my job. And the fact that I know that it is the system that we are in, that you and I are in, that actually makes that possible. We're really blessed. We really are, and it shows. I don't know if you do any recruiting, but when we recruit physicians, people want our life. They want to be able to take care of patients the right way, have the right conversations. And that's it. Not have to worry about all the other stuff. I really like that.
Yeah, no, I completely agree. When I'm talking about talking to other physicians who are interested in joining Permanente, I ask them to ask me how many prior authorizations I've done in the past 6 years, and they usually get mad at me when I tell them the answer. But we won't go down that. Wonderful, awesome. This is such a great conversation. Thank you so much for joining us. Make sure everyone joins us. Our next Permanente Docs Chat will be Wednesday, March 9th. We're talking with Dr. Ruth Cheng of the Northwest Permanente Medical Group about women in medicine as part of Women History Month in March. So I'm really looking forward to that conversation. So thank you so much, Dr. Kulkarni. Join us on March 9th, and have a great Wednesday. Oh no, Thursday. Have a great Thursday.
Thanks very much. Nice to talk to you.
Thanks. Bye.